will focus on increasing the access to high-quality integrative medical education and training to the students from rural, tribal, and underserved areas based on their educational accomplishments and future academic potential. The co-chairs of this session are Dr. Ravi Pillai, Senior Consultant Orthopedic Surgeon, Mount Elizabeth Hospital, Singapore, and Dr. Surya Prabha, Head of Department, Obstetrics and Gynecology, Sri Sathya Sai Sarla Memorial Hospital. We now request the session co-chairs to kindly commence the discussion.
Now we have come to the accessibility to medical education. We have 3 speakers. Our first speaker is Dr. R. Subramanian. Dr. Subramanian currently serves as member, Human Resources Capacity Building Commission, Government of India, New Delhi. He shall speak on the topic, student selection must include non-academic criteria such as aptitude and sense of social responsibility. Video, please. Actually, he is not here, so he has sent us his video, so please listen to it carefully.
It's such a pleasure and a privilege to be participating in this conference on medical education, which I feel is not just timely, but a very important stage in India's progress towards ensuring health for us all to be discussing this issue. I must also apologize that I'm not able to participate physically and be there with all of you, and using the technology that we all have today, this is the next best option. Before I actually delve into the fundamental question of how do we make medical education more accessible, my view would actually have a more fundamental beginning. Before you even get into medical education, when you talk of accessibility, you talk of the people who can be trained as doctors and how do you make it more accessible for them to be educated to become doctors. But for us to understand this, I would actually go back into the more primary question of trained doctors for what? Trained doctors in what? And then coming to the training institution, the medical education system, or the institution running the medical education system. I don't want to talk about the regulation of medical education, which is a different topic by itself, but I want to talk more about understanding health systems. And coming from my background of having lived and worked with indigenous communities for close to 2.5 decades, seeing firsthand how my own medical education either enabled me or disabled me from understanding how my work could have been enriched, and having when you talk of accessibility, you talk of the people who can be trained as doctors and how do you make it more accessible for them to be educated to become doctors. But for us to understand this, I would actually go back into the more primary question of trained doctors for what? Trained doctors in what? And then coming to the training institution, the medical education system, or the institution running the medical education system. I don't want to talk about the regulation of medical education, which is a different topic by itself, but I want to talk more about understanding health systems. And coming from my background of having lived and worked with indigenous communities for close to 2.5 decades, seeing firsthand how my own medical education either enabled me or disabled me from understanding how my work could have been enriched. And having engaged, though it might have been nearly 4 decades ago, seeing the challenges of how admissions to medical education happens, and then seeing the last 4 decades of mushrooming of medical institutions and the challenges of running these institutions. So I want to base my talk on some of these primary questions. So to me, the moment you say medical education, unfortunately, what sets your thinking going, or the stereotype of medical education, is automatically equating medical education to institutions which are run to grant degrees in MBBS or an allopathic system of training. That's a very normative stereotype that all of us have. Now, my fundamental learning the last 30, 40 years is, while my own training of MBBS gave me a lot of skill sets to ensure that I could deliver to society, but I want to ask myself, did the system that I operate in, was it the best system even? So to me, health systems is enabling me, or an institution which is embedded in the historical, civilizational, and the current realistic context of our nation itself. Where I believe fundamentally, when as a nation we are today talking of health and wellness centers, we're talking about International Yoga Day, we're talking of integrative medicine and the contributions of Ayush health systems. Should we even be looking at medical education and access to medical education just being limited to a set of people who can do very well in competitive examinations, can do very well in pre-university or the 12th grade examinations, and then learn how to crack the code in the entrance tests that are conducted today, the standardized entrance tests? Or should we be looking for a wholesome personality and who would qualify to be a good physician for society? Though I might slightly be off the actual mandate of accessibility, I want to fundamentally raise this very important question of not just making it more accessible to the people who can contribute to this kind of thinking, but accessible to the marginalized communities which are operating in a model which is not driven by the economics of healthcare today. So medical education fundamentally has to be built around creating people to operate in a system for which we're creating them in the first place. So to me, I would look at it in 3 different spaces and expand my talk as I go along based on those understanding. First is, how will healthcare look like? How is it looking like today? And how will it look like in the future? And are our medical institutions providing for that? I would not like to spend too much time on that because we'll assume it's a given, and I'll explain what I mean as a given. Second is, how is the space or the workplace in which this work of providing healthcare, for whom we're training the medical specialist, is going to look like? Maybe today, 3 years from now, 5 years from today, in a post-COVID world, what is our understanding of it? And the last is the worker or the physician himself or the medical doctor, where he or she or they together understand how to operate in this workplace, building a set of skill sets in the medical education system to operate in this workplace to deliver on the work. So all these 3 are critical. What is the motivation that we can give to these young people today whom we are training by the dozens and thousands to operate in these ecosystems? And to me, I'll just spend a minute or 2 on explaining this. To me, the work of the future is keeping generations healthy. And this is not going to be easy. Healthy in the context of what we are seeing in the future of the world today, where climate disasters are become normal, is unfortunate. We simply have gotten used to it, where man-made disasters are increasing, whether it is war, conflicts, etc. So the challenge of medical science to meet these requirements are altering. 3, the way we are shaping the ecological crisis and a response to it, the way energy crisis is leading the discussions, and the way technology is getting deployed and appreciation of technology to even understand how medical education should be, is all completely altered. Today we're talking of a convergence mentality. We're talking of training our young physicians not only to be accommodative and understanding of the realities of today from a medical context, but also, though we talk about it in textbooks like Hutchison's, etc., where we talk about taking social history, personal history, we know they're just words that we use to pass an examination, but in real life, how cognizant are we as a sociologist? How cognizant are we as a political scientist? How cognizant are we as an anthropologist in our thinking? So to me, medical education and getting access to this should begin with setting the standards of entry at a level where an understanding and appreciation of the convergence of sciences as a preparatory requirement for me to start participating in the future of the healthcare system. Understanding of enabling me to start appreciating the integration of humanities with the sciences. Now that we're doing that a lot in engineering education, and I think it's time for us to look about it in the health education space. So accessibility is not just for the poor and the marginalized. Accessibility is also to the humanities marginalized people, I would say that way. Because the primary requirement is physics, chemistry and biology for entry. And I would think as much as the core sciences, the basic sciences are necessary, understanding of at least should get this embedded into the medical education, creating an intellectual entry point where I'm sensitized, maybe a pre-medicine examination course or today in the world of online courses, telling young people that you also need to acquire this set of competencies in humanities and understanding of humanities, a set of primary understanding of technology, etc. Now, will this further disable people? There is a problem in that, and therefore, I would come back to the next important thing. Accessibility has to be, whether we like it or not in a country of the challenges that India is facing, is ensuring that we create a healthcare system which is not driven by an economic consideration. Today, the whole model is based on economic considerations, where increasingly private healthcare systems are taking on the role of being the primary healthcare provider. We still live in a country, despite the best effort of the government, to be fair to government, looking at the way Ayushman Bharat and certain a lot of schemes, a lot of far sight has been planned into it, where insurance protection is now being enabled for everybody up to 500,000 rupees now in India, which is possibly the world's largest scheme like that. So many good things happening in this space. Still, the reality is around less than 40% of our patients actually access and use public health systems, which means 60% of patients still use private healthcare systems. And this model is further favoring the corporate structures, which means the entire model is driven around the physician being embedded in ecosystem where there's a primary enabler or a catalyst to create this economic model around him, which means combining technology, high-end interventions, and the physician who's highly qualified in between, trained by these medical institutions. We are perpetuating this model. So we need, and this model cannot be reversed easily, because today these models are all these economic drivers are very urban-centric. And therefore, necessarily, the trainings of this kind of institutions, the medical educational institutions, have also become urban-centric, which means access there itself is sort of restricting the rural kids to come into the system. Even if they do come in, by taking all the standardized examinations, they belong to rich families who can afford to send them to urban areas to acquire the necessary preparatory knowledge to take the standardized tests and get qualified. So we have to look at not just the entries and the barriers to entries into medical education, which is fundamentally skewed towards urban-centric elite family children, but also relook at creating centers of educational excellence necessarily driven by a model which is geographically also located in areas which are reducing the barrier of geographic challenges, which means taking the college to rural areas. Like Vivekananda said, the mountain cannot come to Muhammad. Muhammad has to go to the mountain. And that's the reality of medical education. So if you want to create a new fundamentally conscious, compassionate, rural responsive healthcare system, you got to begin with our educational institutions and move the shift from an urban-centric approach to possibly a rural-centric approach. And as a system, as an ecosystem, move the shift to focusing more on public sector provision of healthcare facilities, move the shift from this economic model which is incentivized currently by the doctor-centric approach to something else. And that's what I'll come to. So to me, accessibility to medical education is not just accessing institution providing an MBBS degree, but accessing institutions which participate in providing HR to the entire healthcare system, which means we have to look at nursing education seriously, we need to look at paramedical education seriously, and all these have to be embedded in geographically challenged areas to attract talent from these places with an incentivized structure where children can only qualify to enter if you've lived for 10 or 15 years in rural areas, and you assure yourself or assure the state to go back to these areas for serving at least 5 to 10 years, the underserved areas. So admission is to underserved children in institutions in underserved areas who will possibly be bound to serve in underserved areas, at least for some part of their lives. I know from the rights perspective, we can't lock them in. freedom of choice should be there, but at least lock them in for some time. At the period of education you get is the period of service you give, something like that. And so, understanding the economic model, shifting the educational space, understanding the healthcare system approach, building curriculums that are more integrative, takes away the dramatics of practice of medicine into a more collaborative, integrative approach, looking at an ecosystem, understanding of HR itself, and therefore looking at multiple layers, and possibly setting and demystifying this understanding of just being a doctor and a specialist to bringing in concepts of mid-level healthcare workers. So I think all this is something which is going to be not easy, but the discourse has to commence, and I think conferences like this enables this discourse. And I would like to take and bring in a more disruptive understanding to this. Amongst the other things I spoke about, whether it's integrative medicine, whether it is collaborative approaches, these are all standardized phraseology that is now coming into the discussion. And I want to take this a level more. Why are we trying to create a community of practitioners who have to be mystified into calling them doctors with special knowledge alone? Let's understand health is a personal responsibility. How do I enable a generational shift in our thinking of also owning up to the personal responsibility of staying healthy, and therefore people promoting this concept, the responsibility also becomes very individualistic, and I don't need a formal training for this. What I might need is a constant push, and with technology today, when India is talking about digital universities, so if instead of a licensing approach, which I need for curing disease, can I create, using these platforms of digital universities, creating a new model of education which teaches people how to stay healthy, for which I don't need to be licensed. As a human being, I have a right to stay healthy, and can we expand this understanding of digital universities to provide competencies of how to stay healthy, which could include lifestyle, it could include our exercising patterns, it could include our dietary patterns, it could include our digital time that we spend on the screen, and so many other lifestyle complications we have brought on ourselves today by growth and technology, using the same technology to solve them to some extent, not just creating a mid-level healthcare worker, but creating a new cadre of public health professionals, which is an embedded understanding where every citizen who's to be responsible for his health also becomes a provider of public health information which he can access through technology for himself. In a sense, I'm talking beyond the three tiers of traditional understanding of healthcare. We'll talk of primary, secondary, and tertiary. I want to bring in this new disruptive sort of a suggestion of saying, why not we create a fourth tier of an individual or at least a family level embedded healthcare provision, for which a medical institution can be simply democratized to provide these digital opportunities for learning how do I stay healthy. I fully understand and endorse that we need licensing when you talk of human life. But as much as I need licensing to sort of help me to understand treatment options, don't we think we can actually build the base of democratized understanding of how to stay healthy? And this is commonsensical. And can we do that? And the last point I want to bring in all this is, for too long have we been ignoring community wisdom. We call it blind practices, we call it, grandmother's therapies, we call it home remedies. But could we build a body of scientific knowledge, understanding and analyzing and evaluating these various traditional practices that exist, appreciating how to embed traditional practitioners with the knowledge in these kind of specialized technological or rural-based institutions, and create an access to a new cadre of practitioners who are already practicing, but you're enabling their practice with a little more nuanced, better understanding of the practice of medicine. You don't have to call them allopaths, you don't have to make them into MBBS doctors, you don't have to make it a licensing process, but you can make it a certifying process where you create a community of practice, a community of practitioners who are embedded in communities for ages who have been doing that, but may not be doing the right things or maybe promoting the wrong things without knowing it even. Can we enable their knowledge? We tried this in the dais. In India, today maternal mortality has been substantially reduced because we built on the foundation of traditional dais and gave them these extra skill sets, extra competencies. We just gave them better understanding how to manage simple deliveries at home or in a setting where they can operate, and learn when to refer them when they cannot. So if you want to really make medical education accessible, to conclude, I think we need an ecosystem approach. We need to take an approach which goes beyond the traditional understanding of how do you enter into a medical education system, lower barriers for the socially marginalized, for the economically marginalized, for the geographically marginalized. Understand that these institutions should be set up in areas where a special provision can exist, that entry into these institutions is conditional to the fact that you lived and worked in those places where you're operating. Create a democratized version of institutions providing not just licensing for interventional therapies and treatments, but something more basic of creating healthcare practitioners, every citizen, using technology as sort of a digital medical university, which is not medical, but a digital healthcare, health knowledge kind of a space where it enables people to stay healthy and well. So creating this, integrating a community of practice of traditional practitioners, all this put together can also create a health systems model which is collaborative, integrative, brings in the best of India into it, and is driven by compassion, is something which is driven by humanism, which is embedded in an understanding of the sciences, not merely as an entry of physics, chemistry, and biology, and then build on that science in anatomy, physiology, etc. But bring in the concepts of political economy, sociology, how society operates, why should we be concerned and compassionate, bringing in some leadership knowledge and behavioral sciences into the system, and make that a prerequisite also. Maybe an understanding of not necessarily a pre-med course like in the West, but can we look at pre-certifications that when a child gets his announcement he's got into a medical college, to the actual time he joins with technology today and so many online courses made available, can you get those knowledge also? All of this together, I'm sure, will enable this fourth tier I'm talking about in healthcare, which is much lower than the primary healthcare we have of today, which will actually reshape health systems, which means automatically impact medical education systems, which will be the real democratization of medical education, which will make medical education accessible to a large number of people, will actually educate us to stay healthy. And that in conclusion would be, I know I'm asking for a lot, but these conferences I see is a beginning of the discourse. A lot needs to be debated. A lot of us have to come together to add to this understanding of what I just mentioned as a few thoughts now. The more deeper we go and the more operational we make it, the more can we advocate to the state to start bringing about these changes. And the dream of making sure that universal health care, it goes beyond just being a slogan, but a lived reality in our country. And that lived reality could be the trendsetter for the rest of the world. And in that space, we can say we are truly marching toward the Jagat Guru that Swami Vivekananda wanted India to do. We could actually lead society, make this world a more healthier place with these kind of ideation that we can concretize into action. So once again, my apologies for not being there. And I would like to thank you all for this opportunity, for sharing a few thoughts. And I know it might be just formative at this stage, but this is a basis for which we can all start some discussions around. I wish I could have been there or in a real synchronous mode, real-time mode with all of you online to exchange questions and answers and ideas. Unfortunately, considering the schedule that I am right now in, I'm unable to do that. And again, my apologies for that. But thank you all so much. I would like to thank Dr. Raghupati and his entire team for providing me this opportunity. Namaste.
We would like to have our summaries and questions, any, if any, at the end of the total session. Now we have a live, vibrant Dr. Srikant Murthy. Dr. Srikant Murthy is Vice Chancellor, Sri Sathya Sai University for Human Excellence, Karnataka. All of us know him very well. He will talk to us about how can current medical education be made accessible to students living and studying in rural areas. Dr.
offer my humble salutations at the lotus feet of Sadguru, respected chairs, esteemed doctors, invitees, participants here and those who joined virtually, and dear students. I'll be talking on making medical education accessible to students of rural areas. So here there are keywords: education, accessibility, students of rural area, and of course, medical education. Let me give you a brief note on Sathya Sai University of Human Excellence. The university was established 2018 with a great motto by Sadguru, Sri Madhusudan Sai, Atmano Mokshartam Jagatitaya. This is self-realization and doing good to the society. We have to realize ourselves that is the ultimate goal of every human being who born in this land, and at the same time seeking or doing good to the society. So the university was aiming at three excellences: academic excellence, research excellence, and of course, the most important thing also is spiritual education or spiritual excellence. So it's a blend of all the three excellence which makes a real human. The other thing is Guru Parampara, creating Guru out of Gurus. Today, that is a need of the hour. Because as we have mentioned, shortage of teachers in various fields of studies, even in medical education. And to extend the facilities and empowering the rural section, rural mass, marginalized sections, and we have to help the underprivileged rural section. The most important and gifts of the two education is always, as Sadguru Sri Madhusudan Sai says, compassionate heart, constructive head, and competent hands. This is one of the major thing that is vision in the university point of view. And of course, high quality education. We are not compromising the quality of education as far as the whole education system is concerned. It is not only just giving you spiritual education, it is the education in general, and of course, I'll come back to the medical education also. And if you look at the quality of a student or a graduate, especially from the education system, and I take the descriptions from Vasishtha and Rama and his brothers. Sarva Veda Vida Dhiraha, Sarva Gnanopa Sampanna, Sarve Samudita Gunaihi, Sarva Bhuta Hiterataha. That means students are repository of Vedas, Vedic knowledge, and also Dhiraha, one is courageous to take the path of spirituality. Then repository of knowledge, repository of good qualities, and of course, contributing towards the welfare of the fellow being always. Sathya Sai University of Human Excellence was established in the rural area, a village called Muddenahalli, in the district of Kalburgi, Karnataka state. And why it was established in rural area is making higher education affordable to the rural, unprivileged students. And most of the girls are deprived of higher education. And Sathya Sai University recognized and identified this problem and encouraging the girls to come to the higher education for possible, and like to encourage and pursue the post-graduation as well as the doctoral programs. And the outcome of this establishment of educational institutes in the rural areas is to develop a sense of gratitude among the students, because students are given the higher education at free of cost, develops a gratitude among them. And definitely this imbibes a sense of duty to serve the similar student. That is what I told, Guru out of Guru. The students who are graduated can teach the similar students and create one more Guru. So this is a self-sustainable model, and create and train teachers who will further contribute to the rural areas. So this is one way, an education, informative education to the transformative education. And looking at the medical education, the need of free medical education. So today, if you look at Indian scenario, and morning all the speakers discussed on this, if you look at today, it happens to be NEET examination. Every year, around 16 to 17 lakh students are appearing for NEET examination, and only 80 to 90,000 seats are available. The competition is heavy. And to crack this NEET examination, students are undergoing as vigorous training from the training institutes, and they are highly expensive. The coaching in training institute to crack the NEET and get a medical seat is becoming so expensive. And if you look at the opportunities for the rural, the exposure is not there. They are not able to compete with the urban students. They are not getting any infrastructure. And rural students automatically out of the race. Only urban will get up and catch these seats. So how can we solve these issues? Why should we deprive the medical education to the rural mass? This is one side. And the second thing is, if you look at the doctors to patient ratio, it is 1:12,000 in India. And the standard from WHO is 1:1,000. So how do you fill up this gap? How do you create good doctors? Not I'm telling more doctors, at the same time, good doctors has to be. And who will be serving in the rural areas? How do you give the health care? Always Sadguru says, every child born in land have the right to education, right to food, and right to healthcare services. Whether it is in urban or rural, every child has to be given the proper health care. And the doctors, morning only, our esteemed speakers told that the people who are not willing to go to the rural areas, or even if they want to go to the rural areas, the lack of infrastructure, safety, and all those things they have mentioned here. And also cost of medical education. So morning we heard it is more than 2 crores for certain disciplines in post-graduation, and lakhs of rupees for a graduation in medical graduation. So these problems are always creating the accessibility problem to the rural mass or the marginalized section. So if you look at the existing model at Sathya Sai University for Human Excellence, my experience in our university has convinced me that we have been successful in bringing higher education to the rural areas. We are already implementing a sustainable model in education. We take the students from the rural areas. We go and select the students. And all the students are given higher education at free of cost. And as a result, as I told you, it developed a sense of gratitude. And because of that gratitude, the students will enter into the service, or they will join back the mission. And I am very happy to say that here, all the 21 postgraduate students from our university have joined back to the mission with a deep sense of purpose to create their brothers as one more guru. Not only gurus, they are taking the administrative levels also. So that means self-employability or employment opportunities is given to the every student with a quality education and the employability at the same time with spiritual motivation. So all these are helping the students to serve for the rural students in our higher education. Now, can we implement the same model for medical education? Is it possible? Yes, of course. We can implement, but what are the additional challenges that you will face as far as the medical education is concerned? One, the need for a sophisticated screening process. As we told, all the students are coming from NEET examination. All merit students also coming from NEET examination, and all the rural students who are not having such coaching also coming from NEET examination. But we have to take, I cannot refuse only, meritorious students. I cannot take only meritorious students. I cannot refuse for people who are coming with financial background. But there should be a barrier for screening such rural students. The students, anyway, it is a policy matter, but we have to have a screening process, proper screening process to choose the candidates for the medical education. Otherwise, pre-medical education may be misused by the mass. And the second one is, we have to create inspired medical professionals who will serve in the rural areas. We can't force them to go and serve the rural areas. The previous speaker told that they should have the background of rural healthcare, and they should have that knowledge of environment that is there. And only inspiration can help them go and serve the unserved. So we have to create an inspired medical professional to serve in the rural mass. And the financial challenges running this model. You know, the intake normally, paramedical college is 100 students. So if you are providing medical facilities or education free of cost, you have to have a state-of-the-art infrastructure for training, faculty, experienced doctors, lab equipment, so on and so forth. And it was mentioned that running a medical college is a white elephant by one of our esteemed speakers. So in such a case, there definitely finance is a major challenge in giving free of education. But we have a solution. Our Sadguru speaks of an effective model which involves 3 entities in achieving the required goal. One is Sarkar, Samaj, or Samstha. There is a relationship between these 3 entities. What is this 3 can do? Look at Samaj, society. It can contribute by CSR activities. It can have these CSR initiatives. Large corporate sectors are there. They can come forward to help the poor, the poorest people. And philanthropists who can come forward to educate as if they are educating one more their child for higher education or medical education, and people who are having selflessness. Selfless individuals can participate in this type of service. Samstha, like ours, giving scholarship, considering the students for 100% scholarship. And the important thing is values-based education. Very, very important, because we are speaking of inspiring students, inspiring medical professionals, ethics, right? All these things should be imbibed only when you give a values-based education, which we are already having that in our system. And employment opportunities. Yes, we have created employment opportunities in the higher education, and same thing can be extended to the medical. We have the hospitals, chain of hospitals in the organization. The doctors who are coming out of our portal can serve in our own hospitals. And allied courses like nursing, paramedical, they are also coming and helping. So there will be a self-sustainable model, and these doctors working in the hospital also training the juniors to come to that. And Sarkar, what the Sarkar can help? It can definitely help in policy making. In the last 3-4 speakers have mentioned on the policy making, because strict admission criteria, only NEET, then quotas, because 50% management quota, 50% government quota. But what about the students coming under rural areas? Then easing the requirements, giving approvals, right? Curriculum-based, inspection criteria, so on and so forth. There are a lot of struggles, there are a lot of barriers. Only government can take it forward to help the institutes like us to come forward to offer medical education at free of cost. And enhanced support towards institute offering free education. Right? Government is also providing scholarships and other things, but that is not only sufficient thing which can learn. They have to give a free hand for giving this medical education. They should not restrict the faculty positions, right? And today, because of the technology, digital technology, Professor Valyathan also is telling, use of technology, you can save the number of faculties joining to the institutions, and you can have lab instructions or some theory instructions online, and definitely we can save. But the government has to agree for this, otherwise, no, only this has to be the professor, and professor has got this much of experience and all those things. If it is possible to ease certain restrictions, then it is possible to have this way. And coming to the conclusion, what is the outcome of this, having a free medical education accessible to the rural sector, a healthy society, accessible and affordable healthcare services to the unprivileged. The rural section will get an accessible as well as affordable healthcare, because they are not able to go to the private. See, I will give an example here. In PG, Swami has established one hospital. One lady was waiting for her child to get treatment, but there was no treatment, and she was asked to go to New Zealand for the treatment, which causing lakhs of dollars. And she told, what are you doing now? I am waiting for my child to die. That is a condition. But now today, a super specialty hospital established by Sadguru Sri Madhusudan Sai to provide healthcare to the people who are deprived of certain things, certain healthcare. So, at the same time, affordable medical education to the rural children. Now, rural children, it is a dream for them to go to the medical colleges. Now, if you have a good medical college in their areas, it is easy for, but provided the free of cost. And these institutions will become a beacon of hope for aspiring rural children. And compassionate medical profession. So that's what our motto, as I told you, compassionate hearts, competitive hands, qualified doctors, and intellectuals. So this is the thing that what our goal is. And lastly, but very important, emancipation of self through selfless service. That is the only, if you look at all satisfied organizations, right, selfless service is the only motto. Achieving the final goal and purpose of all education is Atmanamokshartham, self-realization. If this does not happen and everything else happen, then nothing has happened. If this happens and nothing else happened, then everything happened. Thank you very much.
Now again, we come to an online speaker, Dr. Gary Cooper. Dr. Gary Cooper is Professor Emeritus, Schulich School of Medicine and Dentistry, Western University, London, Ontario, Canada. He would like to talk to us about alternate pathways to medical college, a means of medical education becoming more socially accountable. Saira.
Hello, my name is Jerry Cooper, and my topic this morning is alternate pathways to medical college, a means of medical education becoming more socially accountable. I'm delighted to speak with you today, but I offer my apologies I can't be there in person. In order to participate in the conference, I had to pre-record my comments from my home on beautiful Manitoulin Island in Ontario, Canada. And with the magic of technology, I now appear before you, but unfortunately, I won't be able to take your questions in real time. For this reason, I'll give you my email address at the end of the presentation, should you care to be in touch. I've not delivered a pre-recorded talk like this before, so please bear with me if I stumble on some comments, and forgive me in advance if I cover some topics that are well known to you already. Hopefully there will be some new thought-provoking information within this presentation for everybody at the conference in Bengaluru. Now, just to provide you with some context as to my background, my professional career dates back to the mid-1970s, where I worked largely in addictions medicine at both community-based and hospital-based facilities in the more populated part of Ontario, which is Southern Ontario. It's home to roughly 13 million people and a third of Canada's population. I moved to Northern Ontario in the mid-1980s to work with the Addiction Research Foundation, now called the Centre for Addiction and Mental Health, or CAMH. Northern Ontario is about 7 times the area of Southern Ontario. It's roughly 800,000 square kilometers, roughly the same size as France and Germany combined. But aside from a handful of cities, the largest being only about 200,000 people, it is rural and many communities are remote. It'd take a person about 18 hours to drive from one end to the other. I became a faculty member of Canada's newest medical school, the Northern Ontario School of Medicine, or NOSM, in 2005. And in 2008, I joined as a member of the senior leadership team as the Dean of the Learner Affairs. It was at NOSM that I had the good fortune to work alongside founding Dean Dr. Roger Strasser, who has been described as, quote, one of the few professors of rural health in the world and one of the foremost authorities in rural, socially accountable medical education, end of quote. Following my time at NOSM, I moved back to my hometown in Windsor, Ontario, which is in Southern Ontario, where I had the interesting opportunity to be the dean of an urban-based regional medical campus. It's a rather unique situation, and that there were significant physician shortages in that urban area. And while at Western, I also had the good fortune to be Canada's liaison on the Association of American Medical Colleges Group on Regional Medical Campuses, or the GRMC. And there I represented the Association of Faculties of Medicine of Canada and had a terrific learning experience. Now, all of this is to say that much of my career has been focused on improving health and life in underserviced communities. So on the next slide, here are the main points I hope you'll take from this presentation. I'll explore each of these in more detail as we endeavor to make medical education more socially accountable. First, even though there is often great focus on admission policies and what can be done to bring underrepresented groups into medical college, at the core of these discussions is the issue of physician shortages and/or the inordinate distribution of physicians, which favors urban areas. And I'll go back and forth between medical school and medical college, knowing that some areas use the terminology differently. Second, as I'll outline, we'll have additional opportunities within our, quote, toolbox to effect meaningful change towards a more socially accountable medical college beyond our ability to adjust admission policies. And finally, there are some significant issues that run alongside these discussions that need to be kept in mind, as they have a very real potential to confound and disrupt all of our well-intentioned efforts. And with that as a summary of the main points, let's now dive into each section in more detail. Regarding physician shortages, on the next slide, it seems that this has been a hot topic for many decades, and it still remains with us today. To be sure, physician shortages are not only about healthcare, these issues also impact on the community's social economic health. It's not surprising why these drive the discussion. Some of the earliest work to address these inequities came from Australia, with Reverend John Flynn's efforts in the early part of the 20th century to bring medical care to the remote areas of the Australian outback. This later became known as the Flying Doctor Service in 1942 and the Royal Flying Doctor Service in 1955. It's still in operation, and there are roughly 800 patients that are assisted every day. In 2012, I had the good fortune of visiting their dispatch office in Alice Springs and speak with some of their staff. It's truly inspiring to see this legacy still at work. Similarly, in the United States, the University of Washington School of Medicine's WWAMI Regional Medical Education Program, and WWAMI stands for Washington, Wyoming, Alaska, Montana, and Idaho. They've led the charge in the U.S. to bring medical learners into remote communities since the early 1970s. They've provided early, ongoing, and convincing evidence that training healthcare workers in rural areas leads to improved rates of retention of physicians within those communities. Next, the move to locate medical campuses in rural, remote, and underserviced communities really grew significantly over the past 20 years. In 2016 alone, 16 new regional medical campuses opened in the US, and there was a similar expansion taking place in Canada at the time. Today, there are close to 40% of medical schools in North America that have at least one regional medical campus. In 2016, they accounted for over 9,100 medical students and 34,000 faculty. Now, just like the two medical schools I've been associated with, NAWSM, which opened in 2005, and Western University's Windsor campus that opened in 2008, the hallmarks of a regional medical campus include interprofessional education, collaboration, and teaching and learning that are technology assisted. In terms of medical school admission policies, in North America, there are well-articulated accreditation standards. One can argue these result directly from Flexner's 1910 review of medical education back then. In Canada, the Association of Faculties of Medicine of Canada serves as the secretariat for this rigorous accreditation system of all its 17 medical schools. The Committee on Accreditation of Canadian Medical Schools, also known as CACMS, specifically takes on this responsibility. In the US, the Association of American Medical Colleges sponsors the Liaison Committee on Medical Education, and they ensure that close to 200 medical education programs satisfy the standards. And I guess I should say that CACMS and LCME work very closely together. Now, of all the standards, the one called number 10 speaks to medical student selection, assignment, and progress. And among other things, it states that the final responsibility for accepting students to a medical education program rests with a formally constituted admissions committee. It goes on to say, it goes on to say that the faculty members will constitute the majority of voting members at all meetings, and that the selection of individual medical students for admissions is not influenced by any political or financial factors. There are several other aspects of standard number 10, but to suffice it to say that there is considerable latitude within the admissions committee that where they can operate. A good example is in Ontario. Each of our 6 medical schools has a slightly different approach to attract and facilitate Indigenous people to apply. Some adjust the minimum grade point average, some the required MCAT score, some reserve spots for suitable applicants, and others have specific bursaries. Some universities do all of the above. Now, NOSM's been able to demonstrate some very positive results so far, but it may still be too early to know if these are going to hold up over time. This September's class, for instance, are going to have 26% of the class self-identifying as Francophone students, and 16% who self-identify as Indigenous learners. Now, even though we've witnessed some substantial progress toward attracting successful applicants from underserviced populations and communities, we still grapple with physician shortages. Again, I'll call the example of resource-rich Ontario, Canada, which is where I live, and there are currently roughly 1.3 million people without a family physician. That's close to 9% of the population. And many of those folks, in order to get treatment, will have to go to overburdened emergency room departments. Again, this is a complicated subject, but it seems they're merely tweaking the admission criteria at medical colleges won't fully address the physician shortages or their tendency to prefer urban over rural settings to practice. In the US, the AAMC, the American Association of Medical Colleges, has recently estimated that they will be short anywhere from 40,000 to 124,000 physicians by 2034. It's just 12 years away. And the AAMC also reports that in spite of all the work being done to have medical schools become more socially accountable, little has changed since the early 1980s. In terms of social economic makeup of its US-based learners, most are still coming from very affluent families. So more needs to be done to ensure medical education is meeting the needs of all citizens. And while promising, we do need more impact than what we're seeing from admission criteria modifications. Clearly, there are some additional steps that medical educators can take to move the dial towards greater social accountability. There's been a concerted effort to train medical learners in rural settings, and this has not only improved the rate at which they remain there to practice, it has also better equipped them for the clinical demands of service in a rural area. At NOSM, students spend students spend the final month of their first year living and learning in a rural, remote, Indigenous community. Later, in their clerkship year, that's also done entirely away from the main 2 campuses. We had pipeline programs at both NOSM and Western, and the key here was to build a sense of trust with the communities over time by being visible and engaging with them. This might involve consultation sessions, asking communities their thoughts about the ideal physician they'd like to see trained, inviting them to sit on admissions committees or curriculum committees. When I was at NOSM, we extensively involved communities and invited them to participate with our learners' intensive orientation week experience when they were brand new medical students. I can tell you firsthand the impacts were quite profound for both the students and the communities. And later at the Windsor campus, I witnessed how our standardized patients turned out to be absolutely wonderful educators for our learners. And they too had a sense of pride in our educational program. So while there's many opportunities to appreciate and support the fine work that distributed faculty members make, this part is crucial. And I could give a special talk on this topic alone, but in the interest of time, please know that your efforts will yield very tangible results, particularly if the faculty team is distributed. Now, I understand that scope of practice is a very sensitive subject, perhaps especially so in India, where the High Court has had to give this matter their attention. That said, there were similar concerns in my province of Ontario, but for the most part, these have evaporated in terms of extending the role and the scope of practice of nurse practitioners. That's something that's been doing, they've been doing in the US for some time. There are variances across Canadian provinces, but at least in Ontario, nurse practitioners are able to diagnose, prescribe, treat. They even have hospital privileges. Now, I'm not sure if I've reviewed the most current data, but India spends considerably less on healthcare of their GDP, around 1%, as opposed to countries like US and Canada that are closer to 13%. So advocating for increased funding as well as interprofessional linkages is called for in this regards. And it seems too that India has an unfortunate situation with the emigration of physicians. The country's invested in their training, and then many opt to leave the country. Indeed, India is one of the leading nations exporting trained physicians in the world. And I read somewhere where as many as 5% of all US physicians were trained in India. Again, clearly this is a complex issue, but it needs attention with political leaders so that there's a more equitable solution. And I'll just call your attention to these following two slides and what I'm terming as the perfect storm, because these are issues that could confound our progress. The first issue is climate change, and none of us are immune to this. Even though some of us, it may be a nuisance, for others it can be very catastrophic. And India knows that only too well. You don't have to look too far, even in the last 2 months, in terms of the deaths and the hundreds of thousands of people who have been displaced, particularly in Northeast India. And unfortunately, those issues are not going to go away anytime soon. Second issue concerns technology, and while it can be a powerful ally to our work, it can also be very divisive and dangerous. And this happens in every country. Even in Canada, this past week, we had one of our largest cell phone internet providers go down for a day, and emergency 911 calls were not available. Businesses were dormant. Transportation networks stalled. So, we need to be mindful of the impacts of technology, particularly when they're not working well. And an aging population, while not necessarily a negative thing, it means that there will be increased numbers requiring service from the healthcare system and with more complex issues. Add to that a declining birth rate, and much of the world experiencing this, fewer people in the workforce than in the past. So we really don't know what the impact of all of that is going to look like, but concern is justified. And finally, COVID-19, it continues to play havoc around the world. Healthcare professionals are experiencing burnout at unprecedented rates. There's a strain on resources. People are leaving the profession. And while this is a very complicated phenomenon, it needs a wide spectrum of solutions, it certainly needs our leadership and attention as well. So I've indicated these are complex issues, and forgive me that I've only had so much time to go into detail with some of the solutions. And what's worked for Canada or the US may not work in India, it may not work elsewhere, but it's worth giving consideration to it just the same. So in conclusion, I'd like to just return to these three themes that we've talked about, and they're up on the slide in front of you. Give them some consideration. It may not be enough to just tweak admission criteria. We may need to go a little bit further than that. In closing, I'd like to offer my sincere appreciation to the International Organizing Committee and Dr. Anand in particular for providing me with this opportunity to speak with you today. I hope the talk you found that there's something that will inspire you to take action. If you have need to reach out to me, if you have any questions, my email is there, gcooper5@uwo.ca, gcooper5@uwo.ca. With that, I wish you a good conference and good health.
We've come now to the end of session 2, and I'll summarize our 3 excellent speakers. The first was Dr. Subramanian. He highlighted the challenges and entry requirements for medical colleges in India, and this is true for around the world, as Jerry Cooper has mentioned. He also said that you must understand the changing pattern of the health system. What is present now will definitely change in the future. For traditional exam entry in medical school has always been focused, as Dr. Subramanian said, in the sciences. That means physics, chemistry, and biology. But he highlighted understanding humanities is important because humanities brings out the compassion of an individual. So the medical school entry requirements must change, and it should not be focused on purely sciences. A component of humanities must be there in all medical colleges to enter the medical school. And this is prevalent in many countries around the world. Even in Singapore, all medical students must take humanities as one of the core subjects. So I think the thinking of how a NEET exam is conducted must change, because NEET is focused purely on sciences, and you cannot assess the compassion of an individual on a science exam. He also said barriers to entry into the medical school in India must include the socially marginalized, the economically marginalized, and the geographically marginalized students. And entry to medical schools in rural colleges must take into consideration a rural child in a rural village and how long he's lived in a rural village. Preferably, a rural child should be living 10 or 15 years in a rural village. So you give them extra entry points for that. And after they enter the rural medical college, they should be bonded for at least 10 to 15 years to serve in the rural village. So if you're having a rural medical school, we should look at these criteria of where the child lives and whether he's going to work in that community he goes back to. The next speaker was Professor Srikant Murthy. He spoke about the very competitive Indian setting to enter medical college. The 1.6 million applicants for 80 to 90,000 seats. And most of the applicants go for coaching courses where they pay a large amount of money. And this is prohibitive for most rural children who don't have opportunities to undergo medical training, the coaching initiatives. The cost of medical education deters many children. They are unable to pay to even go for coaching courses. How can they afford to pay to enter a medical school? He also highlighted that we must create inspired medical professionals to serve in a rural village. So the doctors must be inspired and encouraged to go back to the community, and they must be provided with the resources to help the community, and they don't get deterred from leaving the community. And in running a free medical college, there will be financial challenges, and this must be addressed. And how do we address this? He highlighted the solutions in the 3 facets of Samaj, society, Samstha, organization, and Sakar, government. Society can help in philanthropy, in encouraging selfless individuals, and CSR initiatives. The organization helps by providing a value-based education at a very young age. And after they finish their medical school or nursing college, the organization provides an employment opportunity in a rural setting. And finally, we provide them scholarships to do whatever they want to do, and even in encouraging them to go towards higher studies. If they want to specialize, we must give them a platform where they can continue their education even after they leave medical school. Government is very important here. Policy changes must be made in medical education. At the present, if you compare Indian medical education to what is happening overseas, we are stuck in time in India. Most countries have changed their policies and moved away from the traditional English-based medical education, where they've realized we want more compassionate doctors, we want more caring doctors, we do not want intellectual doctors, we want doctors with a heart. So that's a major policy change. The quotas must be improved for underprivileged and marginalized communities, and there must be enhanced support towards institutes like what we'll develop here to provide free education. And the entry into this free medical college must be different from all the other medical colleges because it's a different setting and a different aim for this medical college. The final speaker was Dr. Jerry Cooper, and he shared the challenges of living and working in a rural environment in Canada. Canada is a very large country, but with a very small population. Most of the urban centers, for example, in Ontario, 30% of people in Canada live only in one province. He highlighted there were many physician shortages and maldistribution in communities, especially in Canada. And this will affect medical education and discussions. So there must be changes in medical college admission policies, and even in developed countries, they're still struggling with this. They're still struggling how to adapt and change medical education policies. So this is not a perfect system, and it must be always evolving because countries change, people change, demographics change. He gave the example of solutions. For example, in Australia, which is also a huge continent with 30 million people, there are many rural populations. How do you reach out to them? So Australia came out with an answer with Australian Flying Doctor Service. They were the first country in the world in the 1940s to make sure there are planes which fly out to a rural community which may be 800 miles away. And to this day, that service is still very useful and is one of the key features of the Australian medical system, where even the doctors are attached to the Australian Flying Service and they go out and serve rural communities. And this service serves about 800 patients a day in the whole of continental Australia. North America serves their rural areas by regional medical centers. These are centers where they're located in rural communities, and 40% of medical schools must have one regional medical center. So that is something we should look at, that even in the urban medical schools, they must be encouraged that if you have an urban medical school, you must have a regional medical center where the medical students are then encouraged to go and spend time and work in regional medical center. In Canada, the population is very diverse, and they have a lot of indigenous people living in Canada. So for them, they've changed the application policy to enter medical school by adjusting exam entry scores. So just like we talked to earlier on, they have a national exam. But if you're indigenous, that means you have a tribal population or you're underrepresented population, your entry point into the medical school is lower than the urban child. Finally, he highlighted there should be more training of physicians and paramedical staff in rural and remote areas to improve the competency and efficacy. So once the doctor goes back to that rural environment, continuing medical education is very important, and that must be supported. Finally, he touched on this topic of a perfect storm, which is an aging population, which will change the dynamics of medical treatment and medical school curriculum. And currently, we went through a pandemic. Pandemic has now increased the burnout rate of doctors and health professionals. Many people around the world have left medicine, and nurses have left because of the stresses of working in a very tiring situation. And finally, he says climate change and technology will also change how medicine is practiced and entry to medical schools. So we'd like to thank these three excellent speakers and we'll take everything into consideration in the final analysis and booklet that will be done. So we'll close today's technical session, and the host will give the closing remarks.
Thank you, Dr. Roy Pillai, for that comprehensive summary. And we would like to extend our gratitude to all the co-chairs of the session, as well as all the speakers who could not be with us today, but joined us from around the world and around this country to help discuss on how we can make medical education more accessible for our future medical professionals. And with that, we conclude day 1 of the International Conference on Post-Pandemic Reforms in Medical Education for Accessible and Affordable Rural Healthcare. And we will reconvene tomorrow morning at 9 a.m. for session 3 and 4. Thank you.